International PhD in Progress Seminar series, and this is phase 3 that is organized by the Global South Network. I would like to start the session by thanking the organizer of this weekly seminar series, Dr. Nauman Riyat, who is a lecturer in law at the Leicester Law School and is also the founder and convener of the Global South Network. I am an associate professor in marketing at the College of Business, the University of Leicester, and my research interests are in market studies, marketing and innovation in resource-constrained environments with a particular focus on Africa. So my work investigates the agency of market actors in such settings. So I look into their role of enacting markets, including sustainable markets, brands, market exchanges. I am interested in looking at how actors can be equipped to navigate those challenges, including things like illiteracy, access to resources, institutional voids, and so on. Our discussant today is Dr. Zovanga Kone, and he is a lecturer in economics at the College of Business, University of Leicester. His research pertains to issues related to migration and labor market outcomes. He has looked at the impact of migration on the labor market of the host and origin countries, the integration of migrants, in particular refugees, in the host labor market. Relatedly, his research also has looked at the drivers and impeders of internal and international migration, as well as the efficacy of visa policies on achieving its objectives. We also have Jack Liuta, who is the first peer commentator for today's session. He's a PhD candidate at the Department of Health Sciences at the University of York. His PhD focuses on conflict-related sexual violence in Africa and women's engagement in the mechanisms of response. His case study is in the eastern region of the Democratic Republic of Congo. Last but not least, we have our guest speaker for today's session, who is Roman Gnaegi. I hope I'm pronouncing that right. Yes.
No problem at all.
Yes. Who is a development or humanitarian professional and research student in the Doctor of Social Science DOSI program at the University of Leicester. Over the last 15 years, he's worked as a staffer, consultant, and advisor for non-governmental organizations in Burkina Faso, Uganda, Tanzania, Cambodia, Nepal, Chile, Argentina, and his home country, Switzerland. He currently lives in La Paz, Bolivia. Roman's academic background is in social anthropology, peace and development studies, and global health. His research focuses on the peace-building contributions of health workers and other non-professional peace builders. Roman is going to present his project titled Health Workers in Sexual and Gender-Based Violence, SGBV Care for Refugees, Insights from Frontline Health and Humanitarian Professionals in Rhino Camp Refugee Settlement, Uganda. Roman, you have 30 to 35 minutes for your presentation, which will be followed by 5 minutes for comments, questions of the discussant and peer commentator, and 15 minutes of questions and answers of a Q&A session by attendees. The floor is now yours.
Thank you so much, Winfred. Thank you so much for the introductions and for everybody to be here and read through and help me with my research. It's really appreciated. You can all see the slides, right? That is good. Perfect. So I'm going to try to do this in half an hour and try to do it in a more or less structured way. It's as we've been talking a little bit before the session started. This is towards the very end of my doctoral project. I've handed it in, so I have a lot to talk about, and I might get a bit carried away, but I'll try to keep it in check. So the presentation is basically about a bit my doctoral research in general, and then about one aspect of it, which is this role of health workers in sexual and gender-based violence care and case management. So I'll try to do it in two parts a bit. Here you go. So yeah, the two parts are first the general background of my study and presentation of some of the research results, because actually the context of the larger study is kind of needed to make sense of what I wrote in that little article and what I sort of extracted from my PhD research, from my DSOC research. My general research was about exploring the contributions of healthcare workers to peace building in one rural refugee settlement, which is this refugee settlement called Rhino in northern Uganda. And it was carried out with an ethnographic approach and is a sort of practice-oriented research. I think the thing about this program of Doctor of Social Science is that the idea is to give professionals the opportunity to get, to work towards a doctoral degree, but that relates usually very strongly to their professional background and world and so on. So there's the idea of also having some actionable, results from the research if possible. And then the second part will be the presentation of the article. It highlights one of the case studies from the thesis, because looking at healthcare workers' contributions to peace building, I looked at two different things. I looked a bit more at how do they contribute to peace building between and within the different communities in the settlement, which can be host communities, or in other words, Ugandan local communities and also refugee communities. And the findings of the article, I have to say, are largely based on literature review and some of the interviews. So that ethnographic aspect that comes a bit stronger in the overall thesis isn't really that strong in the article, where I'm more focused just on statements and also insights from local humanitarian professionals and health workers. So starting with just with an overview of my research, the research question, I mean, here very simplified, of course, but was in what ways do health workers contribute to peace building? And this is not something, of course, that I came up with as a topic or as an idea. I put here the sort of two of the standard texts that are out there on it. One on the left is the book Peace Through Health by Arya and Santa Barbara from, I think, 2008. Which was sort of a collection of articles that outlined about sort of theoretically this idea that health workers have a really special role to play in peace building. And from about early in the 2000s to today, there were a lot of different sort of movements or approaches being carried out by different international institutions and also as research topics at university that dealt with this. Another one was called Health as a Bridge for Peace, which was even in the 80s, it started and went into the 90s, into the 2000s. And currently there's a health and peace initiative from the WHO, which is also, of course, links very strongly to this topic. I didn't necessarily work with that so much, but it shows that there's an ongoing interest in these topics. And of course, we're always told by senior researchers that we shouldn't just fill a gap, right? That we should be more original with our research. But to an extent, there's a bit of filling a gap here, because it's been shown that the theory is all sort of there, that health workers have an important role in peace building, but that there's a lack of on-the-ground research and case studies. So in part, also the interest was to see, okay, what can be done to fill that gap of on-the-ground research a bit. Three claims very quickly that are made about health and peace, and why they relate so strongly and why it's of interest to look at how health workers contribute to peace building. Number one, this is from Charlton, 2018. Peace is a prerequisite to health, and therefore peace is the business of all health sector actors. So a healthy society is more peaceful, a more peaceful society is healthier. There is an interrelation that is obvious and is very strong. Two, health interventions can change people's attitudes, which may have desirable political effects. So health is delivered to everyone equally, for example, and it brings people together around this common human need. And it can therefore have effects of bringing communities together that would otherwise be, separated or in conflict. And lastly, and this is very important for my research, because I did this research in a health center in a settlement with frontline health workers. Healthcare workers have certain attributes that uniquely position them for building peace. So they are trained in certain ways. They have responsibilities to communities across different boundaries, and this and their knowledge, their positioning within communities gives them a unique position for building peace. So what did I look at as potential strengths now, more sort of specifically of the peace through health approach, also in my work as, a development and humanitarian professional. Again, the connections and relations between health and peace as fundamental human needs. It's something that it seems we have in common universally, that we strive for these things and we need these things. Health workers are first responders to needs of populations. In many cases where we have, especially humanitarian situations, very difficult situations, there's not a lot of personnel on the ground. There are not a lot of people on the ground that are highly qualified to help with, but health workers are everywhere in the world. If a humanitarian situation is at its most extreme, one of the first steps to get it to improving is that health workers come in. So they are there, quite simply. They are often therefore the only state representatives or service providers in remote and marginalized communities. So if we send in experts, we always have to bring someone in, but the health worker is there, right, in the difficult situation. And something that we've learned, in my academic training and throughout my career now, all these years, we keep talking about it. We need to come away from outside planned, designed, imposed peace interventions. And for that matter, humanitarian development interventions and so on. We need to build on local knowledge. We need to build on context-specific knowledge. We need to build on the contributions that are already made locally, instead of always inserting a foreign element that might not actually, be able to truly work through the issues as they are experienced on the ground. So in other words, using locally available resources and expertise. Talking a bit about the context of the research, I worked in Uganda during 2 years in NGO work. In the northern part of Uganda, there are very strong refugee movements from South Sudan and the Democratic Republic of Congo to northwestern Uganda, the West Nile sub-region where I was based. It's important to say for non-specialists that they're called settlements and not camps for a reason, because there's a major difference, right? The idea that we usually have of refugee accommodation are sort of the tent cities that are placed at certain points, which are thought of, not always are in the end, but as very temporary structures, while the settlement model is a longer term model, which also makes sense for these ongoing crises and these constant cross-border movements, and that people actually stay longer in Uganda. They settle in Uganda. If they get refugee status, they get a parcel of land to work on, for example. They can have a house. So this difference is quite important to point out. Also important, the health system within which the health workers, of course, are sort of placed and work is a so-called integrated health system these days. So it serves both the host Ugandan communities and the refugee communities equally. So the health center where I did my research, both communities come together there. This wasn't always the case. Previously, UNHCR, the UN Refugee Agency, would run hospitals for refugee populations. Eventually, it was seen that these had to be combined. Ironically, also because in many cases, the health provision for refugees was actually better. There was more investment in it because the fundraising was on another level, right, for this sort of humanitarian crisis. So you have a situation where you need to even it out, and refugees actually on people from the refugee community on many occasions complained that they now had longer waiting lines because it was combined with the Ugandan health system. But that's another important point. Yeah, and I think for the research, what's also very important is we have a tendency. There's a lot of good happens in a situation like this. Uganda is a country that has taken on a lot of refugee populations. We have discussions in Europe that are basically going just the way of close the door, right? And these are also models to learn from this context. Okay, what is being done well, what doesn't work, but how can we take lessons from a situation like this for a global refugee management and solutions? And the important point, and I think you're like, there's an awareness in these sort of circles, but not in general. Most refugees actually live and move in the global south and not to the global north. I mean, the numbers are much, much larger of being received in global south countries. Here's just a map to position ourselves a little bit from the UNHCR. Now, I think it's still close to 1.5 million total refugees, or a bit more in Uganda itself. I pointed out, it's not a very good map, I'm sorry, where Arua is, which is the sort of main town of the region where I was based, and then Rhino Camp Refugee Settlement, as you see, is one of a number of settlements there. You see countries of origin, mostly people from South Sudan, but also from the Democratic Republic of Congo. Actually, yeah, from that eastern region of the Democratic Republic of Congo, where conflicts are ongoing. Yeah. And as part of these settlements, Rhino Camp is one of the larger ones currently, and one that receives quite a lot of new refugees still, while others like BDPD, which was at one point the biggest one in the world, is sort of they're not being served by NGOs and the development structures as much anymore. These just a few pictures to illustrate a bit what it looks like. Here, the point for me was more, this is the entrance to the health center. It's just like all the different, logos you see. This is an internationally supported sort of place. This is not just the health system of Uganda, right? We have different NGOs, we have different actors playing an important role here. And this will come up a bit in the research results, that there is sometimes a bit of a lack of understanding of who is responsible for what, because everybody has descended on it, UN agencies, NGOs, the UNHCR, the government, and so on. This is a view of the health center. On the left side is the outpatient ward, where people are being processed, emergencies, but also their normal checkups. And on the right side is sort of what the opposite side is another structure, which is the inpatient and maternity ward. So it's a rural area. The clients who come to the health center are not people of a lot of means usually, because it's a health system in which if you do have the money, you go more private. So this is a health center that serves the general population of these settlements. And as I said, both refugee and host populations equally. Yeah, this is the situation, sort of also from my ethnographic study that I was in the most, is the waiting outside the health center for the services to be provided. There's the TV installed, so it also brings people. Interestingly, in the larger study, one main sort of case is the TV that brings people together. Yeah, that's sort of the everyday situation at that health center in Rhino Camp Settlement. I'm not going to go too much into the methodology. I want to go to the article later, so not to spend too much time on it. But I did what's called ethnographic peace research. The quote here is sort of outlines it as EPR is primarily concerned with understanding and describing the experience of conflict or peace as nested within and filtered through the social and cultural lenses unique to particular peoples in conflict or post-conflict settings. It doesn't give you a rule book of how to do it exactly, but it gives you a sort of ideas of how to engage with a local situation, how to become to an extent like a part of it and learning about it. And I think as is often the case with, or generally the case with ethnography, it's also about not jumping too much to conclusions, right? About having a certain openness and trying to understand or view the situation from the local context and perspective. I did purely qualitative research. I did some interviews. I think that's on the next slide. And I also had to, of course, reflect the role as a foreigner. As was mentioned in the introduction, I'm Swiss citizen. I've lived in a bit all over the place, but of course, it has to be reflected that I come in with a foreign perspective and also with a lot of baggage as a development worker. I was a researcher practitioner integrated with a local organization. I was working there, and I partnered with a local university. So these were some aspects that I go into more, of course, in the thesis. Oops, sorry, jumped ahead. Yeah, these are the key theories. I need to be careful with time, but basically what I want to highlight here is peace building is sometimes seen as a political act, basically. It's being done, by people who sit around in boardrooms or who meet, at high-level meetings. But these theories that I put here together and also how they relate to practice and implementation show that peace is something that is being built by communities. There is the aspect of having, for example, a peace mission from the UN, but then there's the community aspect. There's the aspect of neighbors coming together. For example, the theories of hybrid peace show that any peace building situation has different levels, and they connect from the international down to the local, and all of them are relevant. And we need to look at all of them. Similarly, with everyday peace building is important in reminding us that there are acts that are not assigned to be peace building. That is not, we're going to do a workshop and bring these people together. No, there are things that are being done. For example, a teacher who educates the children in his class in his or her class in a certain way contributes to peace building. The neighbors who have a neighborhood organization that brings them together contribute to peace building. And I guess the important part is that we shouldn't rank them according to which one is more important and which one is less. We should look at them as integral parts of peace building. And within that, therefore, peace through health is a very interesting one, because health workers do certain things that they will do because they want to build peace, or because someone comes in and says, look, we need you as a health worker to help us with this specific peace intervention. But they also do everyday things that contribute to peaceful relations in the societies which they serve. So the data collection was, I'm not going to go into the research ethics clearances. As you can imagine, there were plenty of them, and it should be that way. I absolutely have no doubt about it, but I spent months and months and months and months getting all the clearances to work in this setting. And it was, well, now I can laugh about it. At the time, I didn't find it particularly funny. The good thing sometimes is you don't know what you get into. If somebody would have told me, I probably would have said, okay, I'll do some literature review and leave it at that. So good I didn't. No. It was a rapid or a goal-oriented ethnography. And that's a debate that is probably bigger than this here, but some people would say it's not ethnography, right? Of course, I did live in the place. I was in the place, but at the health center itself, I had to limit myself because I'm full-time employed, right? So I had 18 full days that I was there. I did 24 semi-structured interviews to complement the stuff I got from my observations. So but I guess, please give me feedback about the ethnography thing if you know anything about it. But I think, again, bigger debate, right? The general research findings, before I go to the article. Healthcare workers do make important contributions to peace building, and not only the health worker themselves, but the wider humanitarian community acknowledges them broadly. They know that this is an important actor. Most importantly in this case is the bringing together of communities. As I said, the health system is unified, and this is a very strong signal, right? You have, in many cases, you feel that there's sort of like refugee populations are apart from other populations, but here they're brought together, and through very, very important things, which I think are also important lessons for governments and institutions in Western countries. Refugee community members can become health volunteers. They can work on health steering committees of these health centers, and therefore they are part of how health work is being provided. First of all, they understand their own communities better, but then they also interact with host health volunteers. They can, up to this point, not become formally trained and employed health workers. So you will have the situation that a refugee community member will be a health volunteer, even though back home in South Sudan or DRC, they are fully trained nurses. But it is an important step to opening up the health workforce to other communities. They also do participate in peace building activities for NGOs. So that was something that, through interviews, observations, accompanying in these events, I could see. So there are both everyday contributions to peace building and bringing people together, but also these more planned, interventions. However, the inclusion in peace building related networks, because there are networks, as you see in all the logos, all the different NGOs and agencies and so on, they're all there. They all have their networks, and they talk about peace building, they talk about water, sanitation, hygiene, wash, that sort of thing. The health workers are very often not included in these networks. So they're seen as a peripheral actor, and therefore they're just brought in when they're needed. And overall, their role in peace and peace building is still little understood. So again, this sort of research, or all kinds of other research, this is of course not the only study, can contribute to a better understanding of what they do. And sort of as an overall thing, it is essential to see healthcare workers as complex peace builders, using this lens of everyday peace. Peace building happens both in a structured way, because they're being called in to do a training or something, and in their everyday interactions just as much. And both sides need to be taken account to get to get a complete picture of the health worker as peace builder. Yep. I think I'm going to jump a little bit here, not to take too much time on this. This is how I presented some of the research findings. So, for example, the carpet on which everybody waits to get their nutrition supplements together is one thing that I call the peace through health profile. That this is something that is being done to bring people together, to establish rules that are actually conducive to building peace between communities. General research findings. This is an illustration. I cut it a bit for time, but this is an illustration that shows a bit the different sides of the health work. The activities of everyday peace building and activities explicitly aimed at peace building, and taken together, a complete picture of the health worker as peace builder is provided. And I think the important part, specifically for someone like me as well working in this field, is that usually we're just focused on the activities explicitly aimed at peace building. Also because we can measure them, and because we can measure them, we can finance them. And at the end of the day, even development humanitarian work, a lot of times is about money, right? So you want to have the thing that you can show. We did 5A and 5B thingies, and with that we can now finance it. So this more complete picture, to which also social science research, I think, can sort of bring us a bit, is important. Okay. So now about the article, the results of the article. So the article was one case study, or one side of what they do, because health workers work with survivors of sexual and gender-based violence, and they do sensitization efforts against sexual and gender-based violence in Rhino Camp Refugee Settlement. The article was written, mostly the idea was also to bring in sort of the perspective of frontline health workers. So this wasn't talking to the heads of organizations. This was really talking exclusively to people who actually work on the ground on this issue, and their perspective on things, and therefore to maybe find, some local contextual truth about what's going on with the work of health workers in sexual and gender-based violence. A little bit of context about this issue. Uganda had the longest COVID school lockdown in the world. If I'm not absolutely mistaken, it was almost 2 years. So children stayed at home in the settlements, wherever in the whole country. In the settlements particularly, this had a stronger effect on, a lack of movement, being in close quarters. If there were perpetrators of SGBV, remaining in close quarters with them, a sort of no escape situation. And in general, humanitarian refugee situations are noted for creating heightened risk for SGBV. Limited freedom of movement, lack of support networks for displaced people, youth, single mothers, and so on. A breakdown of support networks in general is noted. So that's why when the identification of the main conflict issues was carried out for the research, it's not really a surprise that SGBV was rated very high. So the overall rates of SGB against girls increased drastically, and yeah, and also as of course an economic crisis coming with this that led to a lot of people, well, children entering relationships at an earlier age to become independent, and also even in some cases, this is from a research article from UNFPA, children being given in marriage at an earlier age. There was a noted, which was hard to see, but a noted increase in teenage pregnancies, basically very, very, very young girls being pregnant. And of course, it's hard to classify that directly always as sexual gender-based violence, but at the same time, we're talking children this in the protection age here. And so, I mean, there's a very strong case to be made that this is illegal behavior and should in some way be addressed. So how do health workers contribute in this case? There are two main roles. One is outreach and sensitization activities against sexual gender-based violence and for a harmonious community relations. And the other one is a formal role of the healthcare workers as a first stage on the so-called referral pathway. They receive the survivors of SGBV to the health center, because that's usually the first stop. They care for and then connect them to other actors on the referral pathway. So protection officers is a thing in these situations. These are, you have child protection officers, you have gender protection officers. They're specialized personnel, usually from NGOs or agencies that accompany. And also to the police and the judicial system, there should be a connection made. This image just shows like one of the campaigns, from the health center itself against violence against women and children. Sexual gender-based violence, of course, not exclusively against women and children, but this is the sort of way it's being done there, right? And I always see a difference between how universities see things and how we do it on the ground. I mean, it's a more complex thing. There's also the LGBTQ community, which is very important to talk about in this case. But here it's more limited to saying, okay, women and children are facing this sort of thing. So I'm going to give just a few quotes that then lead to the results that I'm going to present very quickly on how the sensitization campaigns against SGBV are approached by health workers. This is a quote from a nurse. Normally, when people don't understand their roles in a home, that is where the issues of conflicts come in. So the information you give them is to ensure that each person understands their role. And then it goes into different gender roles, right? And what you can see here is a sort of a bit of a conflict with that more human rights-based approach that will come in with the referral pathway of, like if there's violence, it's a legal issue and we need to address it that way. Here, the health worker more talked about, okay, what did the woman or the kid do that was not in line with the role that they should have within the house? It's a perspective for trying to create a harmonious living through understanding each person's role, and not so much, say handing out flyers. Okay, this is what you can do if this kind of violence happens to you. And this is one quote, but representative of many similar ones. This is the referral pathway as it's being presented in the settlement just outside the health center. So on the left top side, you see that the medical care of here it's called GBV, gender-based violence, survivors is like the first stop, and then it relates to the others, right? To the other stops on the referral pathway. And it goes, as you can see, there's a little court up there. So it goes towards actually taking legal action. That is how it's outlined. That's how it's presented, and that's where the formal role of the health worker is as the starting point. However, in quotes as well here, this is a quote, and I'm going to only read the bold parts, not to take too much time, by a nurse on care and counseling for survivors within this referral pathway. So she said to me, so you bring to her the idea to the survivor who is at the health center. Do you think this idea of taking this man to police is something that is going to work for you? You pose the question then for her to think. You don't decide, but sort of, you bring it up. So the next day you also come. Meanwhile, you encourage this man to be coming also to check on this woman. So in this case, the scenario is the husband, perpetrated this violence. So as the woman gets treatment, they can also be reconciling. By the time they are discharging, they have forgotten about the issues of police. So they go home amicably. So again, it's not, and here I think it's important. It's not about judging what this nurse says or what her approach is, because this is a very complex issue. There's also the security of the nurse herself to be considered, right? But it is a perspective. I think the important part is it's a disconnect from what the referral pathway outlines, which is a clear step towards getting, legal action or representation and addressing it as a sort of legal issue. And then these are quotes about the organizations and the referral pathway, how they work together. This is from a gender protection officer. As a gender protection officer, I can identify a case which I can't manage. You transfer it, refer it to the focal partner to proceed with it, but you'll find the survivor is coming back to you asking, what happened? You referred me there, nothing was done. So there are disconnects on that referral pathway. And of course, for a victim, a survivor partner that is, in a very difficult situation, these are things that can make or break the situation and are really, really serious. And lastly, and this is more about, again, what I already mentioned in the general findings, the inclusion of people in networks, to work together on these issues. A child protection officer said, because the synergy between the child protection is low, it only comes when there is a case. And we don't sit in child protection working group meetings with the health team because they have a different health meeting. So there's a disconnect in this sort of, bringing people together and actually coordinating together, which, if you think about what the referral pathway is an essential aspect.
Roman, sorry for the interruption, but you are left with 2 minutes, okay?
That's actually pretty good. Not too unhappy about that. Okay, so, and the last bit, I wanted to mention because it's quite important. And I mean, health workers experience violence from perpetrators as well. They are not necessarily very well protected people. So here, just very quickly, this is a typical statement from a young nurse who said, someone can slap you anytime when they get annoyed. They beat you up, right? Because you're not in your support system either. These are often health workers that were placed somewhere for work placement, and they don't feel very safe. So very quickly for the conclusions within the last minute that I have, there are positives to the health worker involvement for sure. They are important. They have an important role in guidance and support, right, for survivors. It's a good thing that the first step in the referral pathway is allocated to health workers. There's no ambivalence about that. They are literally on the billboard. They do have strengths as carers and in psychosocial care. I mean, it's better to talk to a health worker first than to talk to someone else in many cases. And some good measures are taken and they should be acknowledged. For example, it was noted by many health workers that teenage mothers and mothers-to-be, these very young kids, they're given separate visiting days to receive nutrition support, for example, when they need additional nutrition, which is particularly important in that stage of life. And to avoid discrimination, that's being done. And there is a sort of health workers are sensitized to these topics, and individual healthcare workers show great initiative and interest for the issue. However, the roles and responsibilities are not clearly defined. There is very limited training for healthcare workers in this very delicate and difficult issue, as reported by them. There's a lack of protection, again coming back to the violence against health work, and there are different cultural views of what constitutes justice for survivors. Is it something that should be mediated in the family, in the community, or should it go to the court system, right? And here the main point is to disconnect from the formal setup of the referral pathway. That conflict is not resolved, so to speak. So more general, how does it relate to my work? There's a problem in theory versus practice in humanitarian settings. We promise to do things, but are the support structures really there? Did we create the context for it to work, which in this case of the SGBV care and response. Lack of clear responsibilities between the different agencies can be really, really problematic in these cases because a survivor doesn't have time to run around between different agencies, right? They need to have a clear pathway. And the expectations on healthcare workers are generally high and they often also change. So their role is doubtlessly important, but they're lacking support. So how do they position themselves? What exactly do they need to do? and also how are they being protected. So the overall conclusion in this case is there's insufficient support from state and humanitarian community for strengthening the local structures and building local capacity to make this really work, this referral pathway and this dealing with SGBV. And with better support based on sound understanding of the strengths and also the limitations of health workers, there could be a crucial one that can be improved. But in this case, it seems like sort of the laying the baseline wasn't really done that much, because the context of the remote settlement, the vulnerability of the health workers, the vulnerability of the survivors, all these sort of things lead to identifying certain actions that would have to be taken to enable this to really be a functioning, efficient, and supportive system for survivors of SGBV and also for the health workers. I think that's it. Sorry, it was a bit more than 2 minutes probably at the end.
Thank you. Thank you very much, Roman, for very interesting presentation and context as well. I'm sure myself and everybody has learned something from you. At this point, I would like to invite the discussant, Dr. Zovanga, Kone, if you have any comments or questions.
Roman, can you please stop sharing the slides so that we can see each other clearly?
Let me see.
Sorry, Zovanga, for the interruption. Yeah, please continue.
No worries.
Yeah, I see.
Yeah, so I echo what Winfred just said. Thank you, Roman, for the interesting presentation. I quite enjoyed it. It kind of reminded me a little bit about my time when I was a postdoc at Compass at Oxford. Compass is a center on migration, but it sits within the anthropology department. So although I was working with economists, we were interacting quite a bit with anthropologists. And I came to appreciate the way they work, their method. So like going and living with the population they're interested in, unlike most of us economists who generally look at numbers, data that's been collected already. So I find this approach quite interesting. I think there's a few things here that I wanted to raise. You mentioned that health workers see solutions within family and between family solutions better than the solution from the legal approach. Is this because that method is more productive? Productive in a sense that it leads to peace much faster than if you were to go the legal way, because also you mentioned that if they wanted to go through the legal way, there's a referral pathway, and often cases fail through. So is this one of the reasons why they do that, or is it just based on an appreciation of the culture of the individual they're dealing with? So that's a question that I had. I found it interesting how the balance of power kind of shifted during the COVID period. The balance of power within household. You mentioned a shift between male and female being breadwinner, because it was easier for female to go and engage in economic activities. I'm not sure whether your study covered that period, but I was just curious what happened after COVID. Was there a return to the before COVID period power balance, or did it stay the same? And something I was also interested in knowing that, or I think would be interested to know, is the difference between the refugees themselves. Because in your presentation and in the work, you mentioned that they come predominantly from South Sudan, Sudan, and the Congos. Are there differences in culture that is reflected in the violences that people kind of suffer in a camp? And yeah, okay. So I think I'll stop here for now. If there's
Thank you
time, I
very
may
much.
ask one or two more questions. But yeah,
Thank
again,
you.
thank you for the presentation.
Thank you, Zovanga. I'm just thinking, should we capture all of the questions now, or Roman can respond to Zovanga's comments initially? Maybe we can take note of the questions and then you respond to them all together. Is there anyone among the attendees that has any comment to make before I can ask the peer commentator? Jack, maybe I invite you to make any comments or ask something as the peer commentator.
Yes, thank you. And congratulations really, Roman, thanks for the brilliant presentation, but congratulations for the work. I was very I really did enjoy your presentation because some of the things that you were explaining, discussing really resonates with my own research on conflict-related sexual violence with a focus on the Congo. And yes, when I see what you have done, I see how you have filled a very important gap on the on health as a pillar, for peace, or let's say of peace building, because there is really a gap that even myself during my work that I did identify. That was even one of the reasons why I avoided exploring the aspect of peace building in my research, because of this gap, and I knew that it would maybe take me some time to discuss, whether to place these debates in a political field or, health or humanitarian field, where really to position this. But I can see how you have really explored this in a very constructive way. And also, there is this emerging tendency in the literature to try and link this aspect of health, peace building, and justice. And I'm very interested to read more and to have further discussion about your work. And congratulations again because of your positionality and being a foreigner, I can say, conducting this research in this context, research about sex and gender-based violence is very challenging, but I see how the outcomes and all the fundings, it's really inspiring. And I have many questions. I'll just ask two. So the first is about the power imbalance, because there is this issue which comes a lot in the literature about sexual violence studies in Africa, where we see during the last 2 or 3 decades, the research was more extractive, where people in the community were, because of these perception of them being vulnerable, their role was more to be consulted, to provide data and to fill in surveys and so on, which is really an issue which led to fundings from the research, which at some point were not fit to the context. And so I don't know if you, and in your research, you spoke with health workers and humanitarian actors, and I know that you did interact at some point with people from the community. So, but well, how did you manage to address these issue of power imbalance? Yeah, I mean, how did you make sure that the voice, I would not say that you gave to the victims or the survivors a voice, but how did you make sure that their voice also counted in your research? I think that would be really the my only one question.
Thank you, Jack. Thank you. Over to you, Roman.
Thank you so much, both of you, for the feedback and the very interesting question. I'll because Jack just asked it now, I'll go to that one first. Actually, I did not. And I think in the article it comes through more clearly that my interviews really were with professionals. This power imbalance is incredibly important. Actually, when we had the conference, I talked about the situation that was relating to that. You know, like especially as NGOs, we very often sort of extract information in a way that is not correct. You know, from survivors and from people that we put into very difficult situations. So in this research, to be pretty clear, I avoided it altogether. I did not talk about, for example, experiences of sexual gender-based violence with survivors whatsoever. I got the perspective, I think in the article I called it perspective for frontline health and humanitarian workers, and limited it to that. I don't know how your research is, whether you already did it or how you're going to do it, but yes, I think it's incredibly important in that case to also be aware that there are certain things that need from us special training to talk with people, to not create further trauma and so on. I mean, which the power imbalance might be extreme when someone is like me working for a foreign organization and coming there, but it's essentially the same if we do it in the UK, in that we need to be incredibly careful with these things. And I think it's very important not to forget that. And so for me, it's interesting with the positionality, because yes, foreigner, and at the same time you have this sort of shortcut with people who work in the humanitarian field. And I think it's always funny that people make it very easy. They think like local is someone who grew up in a rich neighborhood in Nairobi and is sent to a refugee settlement, right? Because they're like, and that's not local. And then that person, when I talk to that person, might have a million times more in common with me than with the person. And that sort of came through in the research as well. Is that like we're this club of, you know, development workers as well. And so we need to think about it both ways. Dr. Zovanga, thanks so much for your questions. Yes, I think there's a big issue about the efficiency of the referral pathway and why the alternative is chosen. And that's actually also from way back in my professional life, even in other country contexts, that, you know, usually we come in and we're like, human rights, human rights, human rights. This is how it's supposed to happen. But people will tell you, if I go through the court system, I spend money, I have to travel to town, I might not be heard. There are high levels, unfortunately, of corruption. I mean, all over the world, right? Poor people usually have a harder time anywhere in the world to get justice. So the thing is like, how do I do this? And the idea is, okay, for example, I had the case, not in this, but I had a case once where someone told me directly to my face, no, I want that the family of the rapist of my daughter compensates us for this. And this is what's going to help us. So it wasn't the cultural, and I think this is a very important point that you're making. It wasn't a cultural belief or whatever. It was like, this is the only chance we have to get justice. So it's a very important aspect. And if I present it in the article in a way that only leans into the cultural perception of it, I need to revisit that, because it really also is about, in some cases, getting the only form of justice that you can get and getting ahead with something that otherwise can lead to just more problems. What happened after COVID? There's sort of things that are sort of a bit too soon to tell sort of thing, right? What I was told by gender protection officers is, yes, that the role reversal during COVID was a huge issue that they noted, that basically that men felt useless, and therefore, and this is obviously not an excuse at all for the behavior, but that there was a sort of moment of, you know, feeling of powerlessness that led to what they perceived as increased levels of sexual gender-based violence. After COVID, in a way, the economy, I think, did not recover, at least immediately. So there are the sort of longer term, the sort of economic long COVID, right? And the social long COVID of it all is, I think, still, and that's something that I think would be incredibly interesting and important to probably research, right, in more detail. But I don't really have that much information on it. With regards to cultures of different refugee populations and what was carried over as well, I mean, that is where it sometimes gets a bit tricky in interviews, because obviously people will tell you, and yes, there were conflicts that were carried over as well from different groups of or ethnicities of refugees. What was interesting from the health worker perspective is that several of the refugee community health volunteers told me that they have found a way to say, I work for the health of everyone. And it helps, not in a perfect way, but it helps with pushing these conflicts that were carried over to the side. That the argument is someone who normally never would receive you in their house, for example, receives you as a health volunteer because they say, okay, this is health, this is a separate issue, this is so that's a sort of illustration of how these things can be, that the peace through health concept really has, in my experience now, in my research, does lead to opening certain doors. But it's also very important to say, because sometimes when we create sort of models, it would be host and refugee as two sort of blocks. And they're very, very much not. And that's something that very early on in the refugee settlement, you realize is that there's actually a mosaic of what host population is and what refugee population is. And in the case of the DRC refugees, there was also the issue that they were the vast minority. So that there is a need to also account for that, because, you know, there might be discrimination for the smallest group from other refugees and so on. So very complex and a very interesting question. Thank you.
Thank you, Roman. We
Thank you
have
for
run
the
out of
responses.
time. Yeah, and I had a couple of questions, but that's very fine because I did ethnography I've done ethnography, a different type of ethnography to what you did. And also I'm interested in practice theory, something we can't get into now. You kept talking about an article. Where can we find it? You say
I think I can just share, or Nauman can just share it with the group as well. It will be published in some way from Leicester, from our summer school thing that I did actually more than a year ago.
Roman, I think you did share with me, but probably I myself, exercising discretion, knowing that, you have just handed in, and some parts of that could be the part of your dissertation. So assuming that thing, I did not share the whole article with them. I only shared the introduction and conclusion part. I fully realized that you did share with me. That is with me, but I didn't because your Viva is going to be held.
Okay.
So
but people can write me directly also very happily, and then I'll share it. Because I'm a bit outside the university system, I'm super confused with this stuff. They say like you can only publish that much and this and so on. I have no idea. I'll just but directly to the email anytime.
Okay, I thought it was published somewhere. Yeah, because I tried a Google Scholar search and so on. But no worries. Yeah.
Apparently it will come out soon. Yeah, that's the idea. Yeah.
All right. So it's 4:01. Thank you very much, Roman. That was a really interesting and insightful presentation. Great discussion as well. Thank you, Zovanga. Thank you, Jack. Thank you, Norman, for making this possible. Thank you, everyone, for coming. Yeah.
Thank you very much.
Thank you
Look
so
after
much.
yourself. Have a great day. See you next week.
Thank you.
Bye.
Okay.
Thank you.
Thank you. Bye-bye.
Bye.